All right. So who is that? Miley Cyrus. And why am I playing Miley Cyrus? A couple reasons. One is we have 3 hours together. Might as well enjoy the time a little bit, right? The second thing is I would make the argument that Miley Cyrus a little bit like life cycles, right? First time you hear about it, you're like, I can't stand this. I don't want to learn this. But if you dive in and get into the details, you will love life cycles. Just like if you really go into the Miley Cyrus oeuvre, you will find some gems. Okay. So, I mean, the woman is great. All right. So last week we talked about introduction to nematodes. Yes? So just as a quick follow-up, something I didn't mention was that last case I presented, the woman from Nigeria who had abdominal pain. Come on in. She had, just so you know, she had strongyloides and hookworms. And someone asked me whether the labs typically do flocculation. And I mentioned, well, sometimes sedimentation, but they don't take that much. So I double-checked with our lab. Different labs do different things. The micro lab here does indeed do a variant of the variant sedimentation technique. But they don't use all the stool they get. They actually use generally about 5 mils and make a slurry of it. So if you give them a kilo of food, they're not looking at all of it. And if you tell them, hey, really look more, they will process more of it. And they have multiple techniques to try to concentrate stool eggs in the stool. So they might try some other things. All right. So we have 3 hours to get. Is that exciting? 3 hours to talk about nothing but worms? This is you're in the front row. You must be happy. Good. So here we go. So the first hour will be on, and we'll take breaks. The first hour will be kind of a survey of the major intestinal pathogens. Paracapillary we'll just touch on for a minute or two, but it's really the first 3 or 4 that are the big problems in the world. Then we'll take a break and we'll come back and do 2 hours on filariasis. So what worm is this? It's the most common helminth infection in the world. Almost 1 billion people infected. One female can lay up to 200,000 eggs. Sometimes the worms will crawl out of the host if the host is anesthetized or otherwise sick. Ascaris, right? So this is Ascaris. By mass, the largest intestinal nematode in the human body. And when you're bored and you want to procrastinate on YouTube, in addition to looking through old Miley Cyrus videos, you can just start YouTubing different worms. And people will show you these great videos from endoscopies they've done when they see the worm. Now, I'd like to point out, you can learn some things from this, right? What does the mucosa look like? It looks normal. Because this adult worm is not invasive in the adult stage. Now I messed everything up. I don't want to do back to the slides. No, we're good. So this is present worldwide. It's because the eggs really do very well in loamy soil. This is the life cycle. We went through the life cycle last week when I gave you that slide that gave you kind of like life cycles in short. So I'm not going to go over this in detail, but just as a quick reminder, this is one of those organisms that comes in through the skin, just like strongyloids, just the semiasis. And then, my apologies. So, sorry, hookworm and strongyloids coming through the skin. Ascaris is the one that's your itinerant teenager, yes? You swallow the eggs, it hatches in the intestinal tract, and then it makes its way to the lungs, where it can cause transient pulmonary infiltrates and eosinophilia. But people aren't usually very ill from this. It's just like a mild pneumonitis. And then the worms migrate really within a week or so to the intestinal tract, where over a period of a couple months they mature to adult worms, they mate, and they release a lot of eggs. So do they cause eosinophilia? The answer is yes, especially in the migratory phase. But when someone has chronic ascariasis, it's not that invasive. It's actually not really invasive at all. So at that point, it typically is not associated with eosinophilia. These adult worms, once they get to the intestinal tract, they almost hold themselves up by just pushing their body against opposite sides of the intestinal lumen. Most people are asymptomatic with this infection. It's a very common infection. Most people don't know they have it, or it just doesn't cause any symptoms. In travelers, so sometimes what you'll see on an exam is they'll show you a barium swallow, and what will you see that makes you think, ah, that's Ascaris? Any thoughts? No, not really. Did someone say gas?
Gaps.
Oh, gaps. Yes, gaps. So what they'll show you is a silhouette in the barium of a worm. And if you ever see that, that's Ascaris. And then someone might say, they're not going to ask this question, but they might say, like I might say, hey, this person's asymptomatic. Do we really need to treat? And the answer is, yes, we probably want to treat, because even though a couple of Ascaris worms isn't going to really harm anyone when they're just in the intestinal tract, these worms are always moving up and down, and it's very unusual. It's not so unusual on exams. In life, it's very unusual, but they have the potential to aberrantly migrate into the biliary or pancreatic duct. So they can cause an acute cholangitis or an acute pancreatitis. So those can happen, but mostly what this does is cause abdominal discomfort. And little children who are repeatedly exposed to Ascaris eggs can develop a heavy burden of Ascaris and then have anorexia. Just don't feel like eating. So this is a little girl in Central America. They dewormed her. These are the worms that came out of her. And you can see this child, it would not be a surprise that she is going to be malnourished just because of the massive worms that were in her. And if she wasn't treated over a period of several years, she's going to have growth issues because she's not going to be properly nourished. So, is it easy to diagnose? The answer is the migratory phase is very difficult. So, when we see transient pulmonary infiltrates in eosinophilia, this Loeffler syndrome, why is that hard to diagnose? How do I usually diagnose Ascaris? Where do I look? In the stool, but the worms haven't even reached the intestinal tract. And maybe some have, but they haven't developed to adults and they're not releasing eggs. So that's just a clinical diagnosis that's hard to make. You may see drug-Lining crystals a breakdown product of eosinophilia. So you may see some eosinophilia if you do a BAL. On exams, you might even catch a larva if you do a BAL. But in general, people aren't sick enough to go to BAL. But a few months later, if you look in their stool, they'll have eggs. Now, when we talk about the insensitivity of stool ova and parasite exam, it's important to appreciate that that differs per organism. So certain organisms are very hard to find in the stool ova and parasite exam. Strongyloides is probably the most difficult one. Strongyloides come out as larvae from the stool, and they're released intermittently and at low amounts. And so it's easily missed. In the best of hands, 3 stool ova and parasite exams from 3 stools on 3 different days give you a sensitivity of about 50 or 60% to pick up strongyloides. Ascaris worms, they're egg-making machines. So the stool is filled with eggs. So 3 good stools negative for Ascaris eggs, the person probably doesn't have Ascaris. And as far as the treatment goes, generally, what CDC recommended is a single dose of albendazole, even though that's not an FDA-approved use for albendazole. Mebendazole, 500 milligrams for a day or 100 milligrams twice a day for 3 days is an acceptable alternative. And a lot of times you'll see, if you're working in other countries, mebendazole is often much easier to find than albendazole. All right, what worm is this? It's a bloodsucker. Hookworms. So hookworms. So hookworms include Necator americanus, which has cutting plates, and Ancylostoma duodenale, which has teeth. They're prevalent in warm and humid areas. They're a major cause of anemia. And as I mentioned last week, they don't just cause loss of blood, but they're also taking up plasma. So essentially they're causing protein losses from the plasma. So essentially a protein losing enteropathy. I personally, I don't think you need to learn all the eggs. To me, it's like if you're going to be looking at stool ova and parasites, I imagine you'll have an atlas next to you. So I don't know on your exam that anyone's just going to show you an egg and then say, what's the worm? But what might happen is that you get a clinical stem, and then they show you a picture of an egg also. And if you know what the egg looks like, then you can have a look at the stem. So what I will point out in this lecture are certain eggs that are just very classic. And these eggs just look very fragile, and the outer part of it is very translucent. So that's a hookworm egg. All right, how did these guys get in the intestinal tract? Where did they come from? From the skin. And so they come in through the skin. And I made a big deal last week about how incredible this is. No? Because it's pretty incredible they come in through the skin. So again, I'm not going to go through the life cycle in detail. I do like this life cycle picture because of this. See what they show the little hookworms doing? So these are the L3 larvae. They're crawling up a blade of grass. And they're just waiting, right, for someone's nice little ankle to come by. They're wearing flip-flops, walking through the dew, just gonna hop in there. Reminds me of ticks. You know what ticks do in the grass? They crawl up to the top. Exactly, and they go like this. They're just waiting. It's called questing behavior. So this is kind of like, I suppose, the analogous worm questing. And in this picture, they actually show the hookworm larva coming in through the hair follicle. It's presumed that that's a weakness, but it still does have to go through intact skin. Then it makes its way to the lung, causes a little eosinophilic pneumonitis, and then it makes its way to the intestinal tract. And there it really sucks blood. There's all sorts of interesting aspects of hookworm. So when a person has hookworms, the females in their intestinal tract release eggs. And what comes out in the stool are eggs. But the eggs land in that person's poop pile, right? And then it takes a couple days, but after a couple days, those eggs will hatch. And out come larvae. And where do those larvae want to go? They want to go into a person. So they typically aren't infected right away. They need to molt. Become an L3 stage larva. So they'll live in the environment for a few days while they're eating something in the poop or in the ground, and then they'll become L3 stage, and then they can infect someone quickly, or they can remain kind of just in an infective stage, just waiting for people for a long time. And they'll move towards heat, those infectious larvae, and they'll move towards touch. And it can take a few hours for the hookworm to get all the way from the outside of the world into our bodies. But if you think about this, this is why latrines can be a problem. Because if you think of where did the worms come from? They came from human feces. And if a latrine isn't kept clean and deep, then the hookworm larvae can just crawl out and sit right where other people come and put their feet. Probably around 400 million people infected with hookworm. This gives you a sense of the intensity or how common these infections are in different areas of the world. Some people call them vampires of the gut. In Decatur, each worm can draw 0.03 mils of blood per day. So it takes about 25 worms to lose 1 milliliter. And ancylostoma, a lot more, 0.15 mils per worm per day. So only 5 worms cause a milliliter of blood loss per day. And it's really more than that, because the hookworms, so you can see this hookworm, right, it's embedded into the gastric mucosa, and it's causing tissue trauma, and it's drinking blood. And then what it'll do is every few days it'll detach, and it'll go somewhere else and reattach. But when it feeds, it releases anticoagulants into the tissue. And so that site where it initially attached will bleed for a couple more days. And so this causes anemia. Now, I like this slide because I study worms. And when we think about worms, and we talk about worms, we often group them together, right? But bacteriologists would never do this, right? Like if I was a bacterial researcher, and let's say I was studying Staphylococcus, and I found out something important about Staphylococcus, I would never title my paper, this antibody is really important for getting rid of bacteria. I would say Staphylococcus. Or this toxin seems to be important for the virulence of bacteria. Like, it sounds idiotic. But if you look in the wormy literature, there aren't a lot of us that study it. And then when we submit papers, people kind of ignore us. So I think to kind of like make ourselves, or our work seem more important, lots of our papers will say, helminth virulence is dependent on blank, or nematode virulence is dependent on blank. But I think we should be more specific because worms are different. So the three most common intestinal worms are ascaris, whipworm, and hookworms. And what this shows you is ascaris and whipworm infections exhibit the greatest burden of disease in a person in early childhood. And as we get older, we probably develop a partial immunity to these worms, and there is a lower number of worms per person in adulthood. That's not true for hookworms. Hookworms just don't display that pattern. People seem to get more and more of a hookworm burden until they hit their late 20s, and then that plateaus. So they're not all the same. So as far as symptoms, the most common symptoms are going to be abdominal achiness, and then symptoms of fatigue from anemia. Certainly a person can have the symptoms when it's migrating through the lung of pneumonitis. When people are infected with the intestinal phase, it's invasive, and some of those antigens will circulate through the blood. And people will have IgE antibodies to that. So a traveler may come back with just hives or itching. That's not uncommon. And then there's something called ground itch. And that occurs when a person has been infected with hookworms in the past, now is no longer infected with them, but is sensitized. And then they go back to an area where there are hookworms, and the hookworms start penetrating the skin, and they develop local allergic reactions. And that's called ground itch. And then there are dog and cat hookworms, and I have a slide or two on this, that are unable to penetrate the basal layers of the dermis. And they'll just keep moving around in the skin, and that's called cutaneous larva migrans. So here's a picture of that. Anyone ever see the movie Marley and Me? Yes. So I don't have dogs, but dogs are nice. And if you haven't seen Marley and Me, in addition to checking out YouTube's for like good wormy videos, you can look at Marley and Me, because even though I don't have dogs, by the end of that movie, tears, because it's a sad movie. But it's nice also. Anyway, in the movie, there's a great scene where, I forget the actor, but very funny actor.
Owen Wilson.
Yes, Owen Wilson. He's funny in everything he does. And he has his dog, and the dog goes to the beach, and the dog does something so that everyone on the beach freaks out. You guys remember what the dog does? It poops on the beach. And in like the movie, there's a big dramatic scene. It's like, ah, the dog's pooping on the beach. We don't like dogs and people with bare feet to like be in the same place. We don't like that because of cutaneous larva migrans. Yes? So because if the dog has hookworms, like the man didn't, he's letting the dog poop on the beach, so maybe he doesn't deworm his dog. And then these hookworms can go into our skin. This is painful. Sorry, this will last for weeks. Because these hookworms, the dogs and cats, they're not evolved to infect us. They really do a poor job of it. So they want to get to our intestinal tract, but they just can't get there.
Does the hookworms, people infected, do they get Loeffler syndrome as well?
Yeah, so hookworms, strongylids, and ascaris, they can all have a few days where they'll have a little eosinophilic pneumonitis. Loeffler syndrome was initially described in the UK with school children, in fact, I think it was in the UK, with school children infected with ascaris. When people say Loeffler's, they're usually talking about ascaris, but this eosinophilic pneumonitis, all three that migrate through the lungs can do it. And there's a lot of other helminths that can infect the lungs. And the classic one would be Paragonymous westermani, which is, I don't speak to you about that. I don't know if anyone else does, but that's a fluke infection of the lung. This infection, this is just more of a nuisance, but it's very painful. It'll just last for weeks. And we used to have a topical cream I think it had, was it albendazole? No, it had mebendazole, I think, and that used to work, but it's off the market. So now we just treat this in the United States with oral albendazole, and that'll kill it. And so it takes a couple months after a person's infected to see the eggs in the stool, and the treatment that's really recommended by the CDC, even though it's not really FDA approved, is a single dose of albendazole. But the thing is, so that's the CDC recommendation: 400 milligrams albendazole times 1, and it's not FDA approved. I have to tell you this because I don't know if you get CME for this. You have to like tell people all this. But the problem in worm science, right, is just people will get their drug approved and then we use it for everything, but they don't bother getting approval for all the different possible indications. And then the recommendations are also kind of interesting. So when people have done studies, a single dose of albendazole, it really probably only cures people completely of all their hookworms about 2/3 of the time. And if you want to get over 90% cure rate, you likely need 3 days. And this was reported by Steinman et al. In 2011, but there are a couple other papers from areas where they have a lot of hookworm infection that also show that 3 days is probably better than 1 day. Now, people know what the issue is with albendazole in the United States? Well, you can get it. You can get it. I mean, you can go to CVS in Bethesda. So albendazole has been around for a long time. It was discovered actually at Merck in the early 80s. It's off patent, but there's only one company that makes it, and that company is called Amidra Pharmaceuticals. So they're the single provider. And the problem is it's a bit of a niche medicine in the United States. And so whenever you have a niche medicine, there's only one company making it, then they can kind of charge whatever they want. So this is a drug that used to cost about $5 a pill 15, 20 years ago, even 10 years ago. And then GSK stopped making it, Amidra started making it, and they started jacking up the price. And a 200 milligram tablet in 2010, we'll do 400 milligrams. A 400 milligram tablet used to be $12. The tablets come in 200 milligram tablets. But 400 milligrams cost $12 in 2010. Today it's more than $400. And what's amazing about this is, if you look at the authors that wrote this New England Journal of Medicine article in 2016, in 2014 the same authors wrote a paper, a commentary, and they talked about the cost of generics in the United States. And they used albendazole as an example, and they said, look at this, albendazole, it's over $200 for 400 milligrams. And so they were kind of publicly shaming the company. And despite the bad press, 2 years later, the company has doubled the price again. And it's not really, I mean, you can argue about the ethics of the company or something, but it's nothing illegal. It's perfectly legal. It's just a problem that everyone recognizes we need to fix, which is you don't have a fluid market when you're selling a drug that has a niche market in the United States. Because, like if you and I want to go into business and make albendazole, which we can because it's off patent, by the time we go through the process of making our factory, getting it all, good manufacturing protocol approved, and doing everything, we'll spend a lot of money. And then, of course, the other company that's making it will immediately just drop its prices until we're bankrupt, and then they'll jack up again. So it's a challenge that we're dealing with in the United States. Brief historical interlude. Does anyone know which war in the United States some people think may have been affected by hookworms? In the United States, that is correct. So it is thought, let me just see how we're doing on time. Oh, we're good. It is thought that the Civil War, I'm not saying that, but there are people that have written articles. If you Google Civil War hookworms, some people make the argument that, that the Southern troops were more affected by hookworms than the Northern troops, and therefore they were more tired and fatigued and not able to fight as well. And I'll tell you, I like that hypothesis because I'm a worm guy, and I give talks on worms, and I can be like, oh, the Civil War. But I actually like reading about the Civil War a fair bit, and if you actually look through what happened in the Civil War, the North lost a lot more soldiers than the South. So it's hard to make the argument really that the Southern soldiers weren't like as competitive as the North. But anyway, they were afflicted more with hookworm. And when we really noticed that hookworm was a problem was after the Civil War. So in the late 1800s, early 1900s, it became increasingly recognized that a lot of people living in southern states, especially where they had fresh, loamy soil and kind of humid areas, they were fatigued, and they were pale, and they were anemic. And the Rockefeller, the Rockefellers actually established something called the Rockefeller Commission, which is kind of the prelude to the Rockefeller Foundation of today, to specifically study this problem. And they figured out that about 40% of people in the 1910s in the South were infected with hookworm. It's amazing, isn't it? That's not that long ago. And that was causing iron deficiency and fatigue. And then they proceeded to do all these great public health interventions. And one of the things they did was they figured out how far a larva can travel. So essentially they would build big sandboxes, and they would take stool that had hookworm eggs with it, stick it in the middle, and then they'd see how far can the larva travel. And they figured out that the larvae can't travel more than 2 meters or so. And so what one needs to do is to dig good latrines that are really deep, over 2 meters. And if you do that, then people won't get larvae when they go into the latrines. And even more important is once the latrine's there, you can't let the latrine fill up. That's a very simple maneuver to really control a pretty terrible infection. They also had some treatments that worked maybe okay. They treated about 500,000 people in a 5-year span. This campaign to eliminate hookworms in the United States went on into the 1940s. And there were all sorts of discoveries made. The United States Geological Survey is an outgrowth of this campaign. Because what they initially did was they would do mapping, like which areas do we need to treat. But then they realized we don't need to do that. We can just examine the soil types. And the soil type was predictive of where hookworm could readily move. So pretty interesting. Here's just a couple pictures from the Rockefeller Foundation archives. And so here was a school in Alabama in 1923, and when they examined the children in that school, every child was infected with hookworms. And they had these great educational materials, and I recommend all sorts of silly things to you all, like check out Miley Cyrus and all her great works. But this, and you can, I like it, but this is actually really worth your time. This is a movie made around 1920. And it's amazing how much science they do. And it's a thing of beauty, this movie. It's educational in terms of hookworm. They'll show a boy running around a farm in the morning, and they'll say, oh, it looks like so idyllic. And then they will focus in on dewdrops. And then they'll have a scientist go and get the dew onto a glass slide, and they'll take it to a microscope, and then they'll take video through the microscope showing the hookworm larvae. So pretty impressive stuff. And if you're into public health, it's worth learning about hookworm eradication in the United States. And then this is another little YouTube video that's kind of entertaining because the music is fantastic. But if you notice the hookworms here, they're much smaller, right, than asperids. If you look at this one down here, you can see how its intestinal tract has blood in it. And it almost looks like there's tiny, you see this hookworm down here? See all the blood in it? So, anyway. Let's go on. What worm is this? It can be intracellular and extracellular. It can cause rectal prolapse. Yes, this is trichurus. Trichurus is weird. Has this little end here, and then this big thick end here. I think I have it on this slide as well. And right, if I was going to go and like invite this worm out, whatever, for a drink at a bar, I would probably approach this end. I'd probably approach this end, right? And this looks like the head, and this looks like the tail, because usually think tail's taper. But this worm's really stupid because this is its head, and this is its tail. So it's not very smart. Not a lot of money out there. But what this worm does is it's invasive. This is straight fecal oral. Someone swallows the egg hatches. Turns into an adult, mates, releases eggs, fecal oral contamination, other people get infected. This affects a lot of people, and this is invasive. This anterior end of this nematode will stitch itself into the intestinal epithelium. So it's kind of like the Loch Ness Monster. It goes in and out, in and out, in and out in the intestinal epithelium, and this large end will just protrude into the intestinal lumen. The eggs actually take several weeks in the soil before they become infected. The eggs look like footballs. A couple other eggs will look like footballs also, but on an exam, if they show you something that's football shaped, that they probably want you to guess trichurus. They have these plugs that when it hatches, the larvae comes out of. So fecal oral, people can be asymptomatic, but when people have a lot of these worms, they feel it, and it causes abdominal discomfort. So you can see whatever animal had these whipworms in it. I think this is from the animal study. This would be very painful. So what does it do to people? Well, in general, most worm infections don't cause diarrhea, but heavy whipworm infections do, and they can cause a frank dysentery picture with bloody diarrhea and pain. Strongyloidiasis, which we'll talk about soon, can also cause diarrhea. But most people will just have abdominal discomfort and won't really have diarrhea. On an exam, they might show you rectal probings, and that happens in heavily infected children. Treatment, again, is generally a single dose of albendazole or ivermectin, but for clinically significant infections, one would treat for 3 days with albendazole. Okay, now this worm is important to talk about. This worm has both free-living and parasitic forms. It can cause autoinfection. And that autoinfection cycle can take off when a person is immunocompromised. So does anyone know what this is? This is strongyloides. Now strongyloid is much less common than the first 3 worms we talked about, right? So people will, like in worm papers or public health papers, they talk about deworming the world. What we focus on are ascarids, whipworms, and hookworms. I forget what they call it. Like something like the devil's triad or something. But something, that, gets people to read the news. Strongyloides is a lot less common. We don't have good numbers on strongyloides. It may be as low as 10 or 15 million people. It may be as high as 100 million people. But the problem is that it can kill people if they receive steroids or otherwise immunosuppressed when they have this infection. Because the larvae are always penetrating through the intestinal tract, or some larvae are always doing that, it's often symptomatic. So something like ascaris, just a small percentage of people will have any symptoms from ascaris, just generally the kids that are heavily infected. But strongyloides, maybe half of your people will really have abdominal discomfort. And in the stulova parasite, we see larvae. In the stulova P exam, we don't see eggs. So here's the life cycle. And again, I covered the life cycle before. It goes from skin into the body, makes its way to the lungs, crawls up, it causes a transient pneumonitis, and then goes to the intestinal tract. It does have some fascinating aspects to its life cycle. It can live for a generation or 2 outside of us. So it can actually complete its life cycle outside of us. And then sometimes its larvae, instead of becoming adults, will arrest in an infectious stage called the falciform stage. They're really thin, and then infect people. What's interesting is sometimes people write, well, they don't really need us because they can just live environmentally, but that's probably not true. No species of strongyloides has ever been carried for more than like 9 or 10 generations outside of a mammalian host. And most of the time, they probably just do 1 or 2 generations outside the body. And this probably serves as a mechanism to amplify worm numbers. But it's really a parasitic organism. So what's the problem? The problem is the worms, when they get to the intestinal tract, they'll mate, the females will become pregnant, and then they can release eggs or larvae. They probably actually, even though we never see eggs in the stool, they probably are predominantly releasing eggs in the intestine, but they hatch within the mucosa of the intestinal tract. So what gets released in the stool are these chunky larvae called rhabdiform larvae. And these can be pooped out, but sometimes these will actually develop into an infective stage falciform larvae in the intestinal tract, and then re-penetrate the intestinal tract, go into the tissues, go back up to the lung, crawl up, be swallowed down to the intestinal tract. So I mentioned last week that if I were to go traveling and I were to swallow 3 ascaris eggs, and then I don't get exposed to any more ascaris, I'm not going to have more than 3 ascaris worms in me, ever, right? That's not true for Strongyloides. It can have multiple generations inside us. We're like the Starship Enterprise for Strongyloides. And we assume that once a person has been infected with Strongyloides, that they carry it for the rest of their life, unless they're treated for it. So, because it's difficult to diagnose by stool ova and parasite exams, does anyone know what we predominantly use to diagnose this infection in the US? I wonder if, this person has eosinophilia, I'm going to get some stool ova and they have some abdominal discomfort. I'm going to get stool O&Ps and I'm going to order this to rule out strongy. What's that? A serology. And that's commercially available. The CDC will also do it for you for free. The CDC has the reference test for it that commercial labs check theirs against. But all the major commercial labs will do it as well. And it's quite sensitive. In the United States, if we see a positive Strongyloides antibody test, we assume the person's infected, we treat them with ivermectin. Why doesn't this work in developing countries? It's a serology. So you treat someone, the serology is still positive, they're still exposed, which is not that helpful, right, in endemic countries. It is helpful in the United States. This map is just more entertaining than anything because it basically tells you we don't know what the prevalence is because neighboring countries will have like, oh, this country has over 70% and this country has almost none. Just probably not. And also, like, where they were making the point in this paper that we don't understand Strongyloides prevalence. That was the point of the article. And if you look in the United States, we say we have endemic strongy in the United States. So we probably do a little, but people cite a study from 1987 that Abraham Verghese wrote. He wrote, people know him, he wrote like something, a book called, I didn't read it, Cutting for Stone, but yes, no, yes. It's a good book. It's supposed to be great. He wrote another, he was an infectious diseases doctor from India. He came to the United States to train, and he worked, I forget where he worked, but somewhere in the middle of the country, and he had a lot of exposure, or treated a lot of people with HIV. He wrote a book called In God's Own Country, something like that. Anyway, I read it when I was an IB fellow. It's a moving book. He's now just become an author. But he did a study, he's the guy that did the study, saying that in Appalachia, 4% of the kids have strongy. Everyone cites that, but I don't know, 87, 30 years ago. So I don't know the yellowness here. I just have no idea. This is just, again, showing you how all over the place the strongy is. In part just because it's hard to make the diagnosis. So we went through the symptoms, basically causes some abdominal discomfort. Sometimes it can cause diarrhea. Just like hookworms, it can cause urticarial rashes. It does also cause something called larva currents. And I have a picture of that on the next slide. And that we think is due to an inflammatory reaction to worms that are reinfecting and then migrating in our abdominal, essentially, probably in the subcutaneous tissue of our abdomen, trying to make their way to the lung. Because they're invasive, it's very common that they have eosinophilia and elevated IgE levels. So here's larva currents, and it's like if you took your 2 hands and you just scratched yourself like this, that's the pattern. I will tell you, I've actually taken care of fair number of people with strongyloides. I've never seen larva currents. But I made the mistake once at a meeting of parasitologists with this table with like a dozen parasitologists, and this concept came up. And I said, larva currents, all the textbooks have it, I've never seen it. Then I got schooled by a very senior parasitologist who had seen thousands of people and said, no, it doesn't. So, larva currents. I think it's more a testing, because it's supposed to be pretty distinctive. You get these diagonal kind of red marks on the flanks. So the real problem is the hyperinfection syndrome. We probably keep this worm somewhat in check so that the number of worms we have in our body doesn't expand too much. But if we treat people with prednisone or TNF blockers, we can see the number of worms expand exponentially, to the point where now you have larvae migrating all over the body. And this causes problems. It will cause whiteout in the lung, it can cause neosymptomatic meningitis, because you have so many worms now re-penetrating the intestinal tract, you can get a gram-negative bacteremia. This happened in the US military after the Vietnam War, because our soldiers went to Vietnam. A lot of soldiers pick up smoking when they go abroad. They come back to the United States, they smoke for 10 or 15 years. They develop chronic emphysema, chronic bronchitis. They would get admitted to the VA. They'd have a COPD flare. What would they get treated with? Prednisone. 5, 6, 7 days later, they present with whiteout and E. coli bacteremia and sepsis. And the problem was strongyloides. Now, we don't have a lot of strongyloides hyperinfection syndrome in the United States, but I tried to get the numbers. I'll tell you, it's low. It is low. But whenever I go to other places and I talk about the work we do in our lab or something, there's always a physician that will come up to me and say, we had a case of strongyloides hyperinfection syndrome where someone died 2 years ago or something, and it's always a tragic story. So in general, and on a test, they like to test this. On a test, they would just give you a picture of someone who comes from Central America or somewhere in the world which is going to be endemic for strongies, so much of the tropical world, and then the person will get prednisone or a TNF blocker, and several days to a couple weeks later, they will present acutely ill with E. coli bacteremia. The answer is strongy. And there very well may not be any eosinophilia, because when we get a bacteremia, the immune response to the bacteremia will suppress the eosinophilia. So that's something that might be asked about. And then this is just in case someone's really nitpicky, you don't need to really know it. But there is a difference between hyperinfection, which is just acceleration of autoinfection, and disseminated. Disseminated strongyloidiasis means that there are symptoms due to larvae in organs beyond the intestine. I told you stool lobe parasite exam is insensitive for strongyloides, and that's true, but when someone has the hyperinfection syndrome, it's loaded. This was from a case at Washington Hospital Center a while ago now, 8 or 9 years ago, that a colleague of mine shared with me. And you can see this stool, I mean, there's adult worms, there's L3s at different stages, so it's not a mystery. If you think of hyperinfection syndrome, you just get a stool. It should be readily possible. So how do we diagnose this? In the United States, we do serology. One can do ovent parasite exams, and you really want to do multiple, but again, the sensitivity is kind of low. People will break things up like, intestinal biopsies or duodenal aspirate, but really those are pretty insensitive. There are fun things one can do. So you can put some stool in a plate where someone has inoculated bacterial cultures. Maybe this is, I don't know, maybe it's like staph or something that someone purposely inoculated on a blood agar plate. Then you put a little poop somewhere in the plate, and what you'll see is these linear streaks because the worms are essentially pulling the bacteria through the agar plate. And there are other things that can be done. Someone suggested and published making a moat in an agar plate, putting poop in the middle, and then you just look in the moat. If you ever want to diagnose strongyloides, tell your microlab to try some of these fun things. You can call me and I can tell you some of the fun things they can do. And CDC can help you, and they can do the serology. So how do you avoid this strongyloides hyperinfection syndrome? Like say you have someone, 22-year-old young woman, she immigrated here from El Salvador. Turns out she has lupus. Someone's going to hit her with steroids. What should you do? So you can do that. And in fact, a lot of bone marrow transplant centers in the United States will do that. Check the serology. If it's positive, you treat. But what if they need to start the steroids today because they're not planning on a bone marrow transplant in the future? They just want to treat her. They want to treat her with the prednisone. What can we do? Yeah, just give her some ivermectin. It's safe. Just give her the ivermectin and you're good. So the preferred, the drug of choice is ivermectin. You give 0.2 mg per kg per day for 2 days. And for hyperinfection syndrome, you would treat Nematodes. It gets complicated. Okay, so this worm I talk about because the Uniformed Services University, and specifically Dr. John Cross, who unfortunately passed away several years ago, but was really one of the world's preeminent parasitologists. They played a very big role in discovering this worm and essentially identifying its life cycle. Does anyone know what this is? It's an unusual worm because when it infects someone, it typically progresses to the point of causing death if it's not treated, which is bizarre. So, yeah, so it's capillaria. It's been renamed paracapillaria. And it has a very complicated life cycle, but ultimately, people get infected by eating undercooked freshwater fish. And the problem is, I think I have on the next slide, but it causes borborygmus means rumbly, grumbly tummy. And it causes abdominal pain and watery diarrhea. And what happens is, these adult worms, people eat the fish, it's infected, the larvae come out, they infect the intestinal mucosa, but then they reproduce there, and they make young there, and the young turn into adults, and it just expands and multiplies, and it ultimately leads to death. So very unusual infection. And then this is a very common infection. Actually, arguably the most common intestinal nematode, but I saved it as the last one because clinically it's the least important one. But we can tell funny stories about it. So it's more of a temperate worm infection. Might make people itch their bottoms. Pinworms, right? So it's good to learn a little about pinworm because you may encounter this in your life, or you might have friends that encounter it. There's just really one big teaching point. The teaching point is, don't freak out. It's just not a big deal. A little pinworm, you can do it on your own time. You can YouTube some pinworm videos, because there's a lot of them out there. You're not doing anything to anyone. You're just, in the mucus layer, not bothering anyone. But people get freaked out when they see them. So parents might see these wriggling little, ½ centimeter to 1 centimeter white worms when they're cleaning a baby's diaper. And people lose it. And you just have to tell people, it's probably doing nothing to your child. So can it do anything? The report is that, a lot of children will have perianal itching from the worm. They might. I don't know. It's hard for me actually to figure out exactly how it does it. It's so non-invasive. But maybe it causes people to itch. Maybe people just scratch themselves in the tushy and we like to blame the pinworm. I don't know. If you look in the literature, there are case reports of pinworms causing appendicitis. Does it do it a lot? Probably not. Is it just, the kid had pinworms and there were some pinworms in the appendix? Maybe it caused it. So this is what people talk about: appendicitis, perianal itching. But that's pretty much it. We're the only host for anaerobius formicularis. It's straight up fecal oral transmission. It does not auto-infect us. It does not complete its life cycle inside of us. But those eggs are readily, within hours of coming out, they're infectious. And so kids will reinfect themselves all the time. And then parents get infected, right? And you might say, oh, come on, I have a kid, parent, how's the parent going to get infected? But if you're asking that question, it's a ridiculous question. Because, right, the first time you have a child and you're changing a diaper, it's like a scientific experiment. You're there, you have all your accoutrements, and you're really careful, and you're wiping everything nicely, and it's pristine, and you unglove your hands, and you're all set. By the time you have 3 child, right? It's like you're sitting there, you've got the phone in one hand, the ham sandwich in the other, you're wiping the poop, and who knows? But, you know, these eggs are microscopic, so people get infected, and what happens is it'll ping pong through the family. So I'm going to give you helpful advice in a minute, but we'll take a 10-minute break between talks. But I'll share with you the ballad of the pinworm. Do we have people here that went to Eustis for med school? Have you heard the ballad? You don't remember the ballad? This is like my best story. You don't remember the ballad. Okay, so this is the ballad of the pinworm. So years ago now, I moved from DC to the burbs, and you know, that was a shock on the system. Moving to suburbia, we were city folk, suburb folk, with a minivan. I had little kids at the time, and no joke, the very first, as we're moving in, a man knocks at the door. You know, I don't know, he says, Comcast, cable guy, want to sell you some cable. I'm like, okay, and he comes in, and he says, you know, you want the regular package, the super package, or the ultra deluxe max package with 5,000 channels. And we'll give you that package, you know, for nothing for the first few months. My kids are there, and they're like, go dad. I'm like, okay. We're in. And we buy like some ridiculous 5,000 channel package. And so we have that package, and I realized there are a lot of nice science shows, right? Because there's like 15 different, you know, National Discovery and Smithsonian and this, I don't know, all these scientific channels. Discovery Wild. And so I started watching those with my children, and I noticed like they have all these videos of like these large animals that are really cool. And you're supposed to, you know, the lions and the tigers and the sea turtles, right? And what does the mama sea turtle do that's so incredible? Like when they show a video of the mama sea turtle, what do they say? Look at this amazing animal. And what does she do for her children? Yeah, she is a creature of the sea. But instead of staying in the sea, for her progeny, she goes out in the middle of the night, and they'll play like some very dramatic music because like she's very swift in the water, but on the beach, she's now kind of cumbersome, right? And so, oh no, like she can barely like walk on the beach, like nothing is touching this thing. She's the size of a Volkswagen, but it's ridiculous. Like nothing's happening to this turtle. So she goes up, she digs a hole, she lays her eggs, she goes back in the water. And we're supposed to be impressed, right? Oh, that's amazing. And you know, I'm not like downplaying it, but yeah, it's cool. But it's not actually as impressive as what the mama pinworm does. Because the mama pinworm, and no one shows it on the videos, but the mama pinworm migrates out. This is true. She has a belly full of eggs. And does she like go out of what she does? So she leaves, she exits the rectum. This is true. And does she just dig a little hole, lay her eggs, and go back in? She does not. She migrates out, we'll say it happens at night because it's cooler at night, and then instead of just laying her eggs, she actually, not always, sometimes she just shrivels up and dies and someone scratches her and she bursts and the eggs go all over. But sometimes, that happens sometimes, but sometimes she'll crawl out and she will violently evert her uterus and spray eggs everywhere, and in so doing dies. It's kind of sad, but she did it for her kids. But what does that mean practically? So you might be like, Ed, that's just, we're getting distracted. But there's some points here. First of all, where are the eggs? Are they in the stool? No, they're on the skin. So if you want to look for it, which you don't have to do, you need to do the little tape exam, right? And every military hospital will have something cooler. You should ask for it. It's called a swoob. Anyone ever used a swoob? It's like a sticky stick. I don't know, it looks like a lollipop stick. The problem with tape is, and she's grossed out. The problem with the tape, the Scotch tape test is the sticky stuff is pretty refractile, so the lab will have to add xylene or something to get rid of the sticky stuff to look for the eggs. But you can do it. But if you get a swoob, it's even better. It just looks like a tongue depressor, but it has sticky stuff on it. And you just, so here's what you do. All right, first, if someone tells you their kids have pinworms, the first time you can just believe them, okay? But in the case where this keeps happening over and over again, at some point you want to make the diagnosis because maybe you and the parents are talking about different things. So if you want to make the diagnosis, You tell people to come into your clinic first thing in the morning. You tell them not to poop and not to shower. Because if you tell someone, oh, I'm going to examine your tushy when you come in, a lot of people are going to like clean up their tushy, and that's not what you want. You want them to come in with dirty tushy. So they come in. This is practical advice. And they go and they face down and just like kind of like go perirectal, and then you send it to the lab. It's readily diagnosed, the eggs. And it's easy to treat. You can treat over the counter with albendazole or mebendazole, but you can just go and get parental. There's a lot of formulations of it that are commercially available. You go to CVS, and they all work well. People always say that this fails. It doesn't really fail in the sense that we don't think there's true pinworm resistance. This is actually maybe helpful advice. So what you do, the reason it fails is because it's ping-ponging around the family. So you treat it just the way you would scabies. You go and you tell mom and dad, listen, your kid probably has pinworm. We're going to treat your kid. And I know you're not infected, and dad isn't infected. But you know what? We're just going to assume you are, just to be on the safe side. And you tell everyone to take the pinworm medicine. Then you tell everyone to shower up, cut their nails, take all the bed sheets, all the pajamas, put it all through high heat in the dryer, and then 2 weeks later, don't even come back, I don't even want to see you, retreat everyone. In general, that takes care of the problem. If that doesn't take care of the problem, then call ID, give me a call, confirm the diagnosis. Okay, just a couple concluding thoughts before we stop. Health and control programs. Military physicians always ask me, not always, like once a year, someone will call me, say, Ed, should we set up a health and control program? The answer is, it's really good. Empiric therapy is really quite safe, and if you take a population that's heavily infected with intestinal worms, then you can do a lot of good by doing a deworming program. The thing is, it's not a one-shot deal. You can't come in as an American from the outside, go into a country, just do like one round of mass chemotherapy and leave. That doesn't help anyone. So if you want to do it, you have to establish a relationship with the infrastructure that's already in place and put in a long-term program for a successful deworming project. There's a lot of data for how they work, but I just love this slide. This is derivative of albendazole or mebendazole. It's called thiabendazole. We don't use it anymore. But it just shows a child on a growth curve, completely off the growth curve. They get dewormed, boom, back on the growth curve. And then there's this whole issue of we need to think about worms if we work in the United States. And I already made the case last week that in the military, we send soldiers everywhere in the world. So you do have to think about them. But even if you're not, like if you leave the military and you start working civilian practice, it's hard to find a corner of the United States where there isn't some population that has worm infection, especially immigrant populations and also travelers. So this is a study, so over 10% of Americans are immigrants. This study came out of St. Paul, Minnesota, right? And if someone said, ooh, St. Paul, Minnesota, hotbed of tropical infections, you'd say, no. But they have a large immigrant population. So look, from 1996 to 2002, this hospital diagnosed over 300 cases of Giardia, over 100 cases of whipworm, ascaris, strongy, and almost 300 cases of hookworm, and a lot of other tropical infections as well. So they're out there. When people tell me we never see these infections, I sometimes wonder, well, do you not have them, or are you just not thinking about them? Because if you don't think of them, you'll never make the diagnosis. So when you have cases you don't understand, or that have eosinophilia, in people that are immigrants or endemic travelers, you should think of worms. And so I have a couple reference slides if you want to know mechanisms of some of these drugs. But here's my summary. Helminths, especially intestinal nematodes, are highly prevalent non-segmented roundworms. In certain populations, they're highly morbid. Honestly, most Americans that get them, it's not very morbid. Probably it's no big deal at all. But in little children on the border of starvation, with high burdens, very morbid. Frequently associated with eosinophilia and high D levels. When should you think about them? If you have someone that has unexplained abdominal pain, unexplained nutritional deficiencies, new allergic symptoms or rash, or eosinophilia, and they're an immigrant or they travel. And a very simple diagnostic plan, like, oh, I wonder if this person has intestinal nematodes. 3 stool open parasite exams and a strongy serology. That's a really good screen. If they were in a schisto, I'm missing a T there, but in a schistoendemic area, which is a fluke, but it can also cause eosinophilic enterocolitis, you can get a schistoserology as well. And finally, if you have someone that you're going to immunosuppress, and they are an immigrant from an endemic country, you should either check a serology or empirically treat them with ivermectin. So there's a little turtle, and let's take a break. So let's come back in like 10 minutes, and we'll do 2 hours of polarity. Okay? Friday.